Welcome to This Week in Family Medicine. This week we're covering 7 notable papers spanning cardiometabolic health optimization, the patient and caregiver experience in primary care, and the digital and clinical competencies shaping modern practice. Let's dive in. We begin with hypertension and cardiovascular risk, which remain central pillars of daily primary care practice. In a cross-sectional study, researchers evaluated the prevalence and predictors of blood pressure control among 460 hypertensive adults at a public primary health clinic in Malaysia. The study achieved an excellent response rate of nearly 97%, with a participant group that had a median age of 64 and was predominantly female. Alarmingly, only about 41% of these patients had controlled blood pressure. When looking at what factors were associated with successful control, the researchers found that older age, female gender, and not having diabetes were significant predictors. Specifically, women had more than double the odds of having controlled blood pressure compared to men. Medication complexity also played a role. Patients taking only 1 or 2 medications had roughly double and nearly triple the odds of achieving control respectively, compared to those on more intensive regimens. Most notably, patients who had documented home blood pressure monitoring had a more than 4-fold increase in the odds of achieving controlled blood pressure compared to those without documented home tracking. This highlights a clear clinical takeaway. Actively encouraging and documenting home blood pressure monitoring is one of the most powerful tools we have to improve control rates in our clinics. Moving from blood pressure control to overall cardiovascular risk stratification, another study in BMC Primary Care looked at how we can better identify high-risk hypertensive patients. This longitudinal cohort study of 243 hypertensive adults in Spain evaluated the predictive value of combining the triglyceride glucose index, normalized by waist circumference, which serves as a surrogate marker for insulin resistance and visceral adiposity, with the American Heart Association's Life's Simple 7 cardiovascular health score. The researchers followed participants for at least 2 years. They found that patients in the highest quartile of this metabolic index had more than a 5-fold increase in the risk of experiencing a composite outcome of organ damage, cardiovascular comorbidities, hospitalization and death, compared to those in the lowest quartile. Even those in the second and third quartiles showed roughly double and triple the risk respectively. Furthermore, only about 10% of the patients met the ideal criteria for 4 or 5 of the Life Simple 7 metrics, while over 40% met only 1 or 0. Combining this metabolic index with standard lifestyle metrics can significantly strengthen how we stratify and manage cardiovascular risk in our hypertensive patients. Our next theme centers on the patient experience, care continuity, and the complex support systems required for vulnerable populations. In the Scandinavian Journal of Primary Healthcare, a large-scale cross-sectional survey of over 2,000 cancer survivors in Sweden explored the barriers these patients face when accessing primary care. 2/3 of the survivors reported experiencing at least one major barrier to satisfactory primary care contacts. The most common hurdle reported by nearly half of the respondents was a lack of continuity in their care, followed closely by accessibility issues. Patients who had additional comorbidities, more cancer-related health problems, or who lacked a regular primary care physician, had significantly higher odds of experiencing these barriers. Additionally, survivors who did not have an active clinical handover had higher odds of perceiving barriers than those who were still receiving active treatment. This underscores the critical importance of establishing a dedicated primary care home and ensuring a formal active handover process when patients transition from oncology back to primary care. This need for relational continuity and environment-level support is echoed in a qualitative study from BMC Primary Care that explored what makes a consultation successful. Researchers in Botswana interviewed 17 doctors and 32 patients in public primary care clinics. Both groups agreed that the key facilitators of high-quality consultations include establishing a strong doctor-patient rapport, ensuring continuity of care, providing adequate time, maintaining strict confidentiality, and improving the physical environment of the clinic itself. These findings remind us that the core elements of excellent primary care are universal, transcending geographical and economic boundaries. However, when supporting families in our practice, we must also recognize the limits of individual lifestyle interventions. A study in BMC Primary Care investigated caregiver burden among 55 primary caregivers of children with autism spectrum disorder. Interestingly, the researchers found no statistically significant relationship between the level of caregiver burden and the caregivers' physical activity levels, exercise self-efficacy, or perceived benefits and barriers to exercise. Instead, caregiver burden was significantly associated with the number of children in the household, and the duration of caregiving. For family physicians, this is a crucial reminder that simply advising exhausted caregivers to exercise is unlikely to alleviate their burden. Instead, we must focus on connecting them with tangible systemic support services, respite care, and community resources. Our final theme examines how digital health literacy and professional training shape clinical practice. A cross-sectional study in BMC Primary Care evaluated the factors that influence telemedicine acceptance among 277 adults visiting a family health center in Turkey. The study revealed that a patient's digital health literacy is a powerful and direct predictor of whether they will accept telemedicine services. While a negative attitude toward artificial intelligence was associated with lower telemedicine acceptance, the study's mediation analysis showed that attitudes toward artificial intelligence did not actually bridge or explain the relationship between digital health literacy and telemedicine adoption. This means that to successfully integrate telemedicine into our practices, our primary effort should be directed toward improving our patients' basic digital health literacy, rather than focusing solely on their perceptions of advanced technology like artificial intelligence. At the same time, maintaining high clinical standards across our healthcare teams is essential for safe prescribing. A nationwide cross-sectional study in Nigeria also assessed the knowledge, attitudes, and practices of 687 healthcare professionals regarding oral anticoagulants. While the majority of physicians, pharmacists, and nurses demonstrated a positive attitude and good overall practice, most healthcare professionals across all groups possessed only fair baseline knowledge. Notably, nurses had significantly lower knowledge and attitude scores compared to pharmacists, while prior specialized training was a strong predictor of both superior knowledge and better clinical practices. This highlights a clear opportunity for primary care leaders to implement multidisciplinary targeted educational programs on anticoagulant safety to minimize prescribing and monitoring errors. If you only have time for one paper this week, make it the Malaysian study on blood pressure control in primary care. This paper provides a powerful, real-world reminder of the clinical impact of home blood pressure monitoring, demonstrating that documented home tracking is associated with a more than fourfold increase in the odds of achieving blood pressure control. Here are the key takeaways from this week in family medicine. First, prioritize and document home blood pressure monitoring for your hypertensive patients, as it is strongly associated with achieving target blood pressure control. Second, when managing cancer survivors, focus on establishing a regular primary care physician and ensuring a structured handover from oncology to overcome major barriers in care continuity. Third, recognize that caregiver burden for families of children with special needs is driven by systemic factors like family size and care duration, meaning these families require concrete social support rather than just lifestyle recommendations. Fourth, to boost telemedicine adoption in your clinic, focus on assessing and improving your patients' digital health literacy, which is the primary driver of digital care acceptance. And finally, implement ongoing multidisciplinary clinic training for high-risk medications like oral anticoagulants, as targeted education is strongly linked to safer clinical practices. That's your roundup for this week in family medicine. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.